Right, postpartum assessment and nursing care is for chapter 9 and 10. Postpartum is considered the 6 weeks following childbirth. The goals of postpartum care are to assist and support the woman's recovery to the pre-pregnant state, identify the deviations from the normal postpartum assessment, educate the mom about self-care and newborn care, and promote bonding between mom, baby, and family. Postpartum hemorrhage is one of our big concerns, one thing that we're really monitoring for. And in the first, usually postpartum hemorrhage can occur in the first 1 to 2 hours postpartum. We're going to observe very closely for hemorrhage in the 1 to 2 hours. Hemorrhage is considered a blood loss greater than 500 milliliters in a spontaneous vaginal delivery and greater than 1,000 milliliters in a C-section. So we do an EBL, estimated blood loss, of 500 milliliters in a spontaneous vaginal delivery and an EBL of 1,000 milliliters of blood loss in a C-section. And that's what we would consider to be normal. So we're observing for potential hemorrhage, for it to be greater than 500 mils in a spontaneous vaginal delivery and greater than 1,000 milliliters in a C-section. So we can have early or late postpartum hemorrhage. So early postpartum hemorrhage is what it says, early. It occurs within the first 24 hours after birth. Causes for early postpartum hemorrhage are uterine atony. That means atony, atonic, no tone to the uterus. It's not clamping down like it's supposed to be. Lacerations that we may have missed, and hematomas. Late postpartum hemorrhage occurs after that first 24 hours and can occur up to 6 weeks postpartum. And causes for a late postpartum hemorrhage would be retained placental fragments. So if the whole placenta doesn't attach appropriately, and the placenta has not come out fully, they usually inspect the placenta, but there's always a risk that some of the placenta may have remained in the uterus. It's a huge problem and potential for postpartum hemorrhage. Or subinvolution of the uterus. Subinvolution meaning the uterus is not involuting or going down or clamping down appropriately. Primary dangers of postpartum hemorrhage is hypovolemic shock. Okay, see page 237 in your book for more information. The mom is kept in labor and delivery for close observation until she is considered stable, which is usually that 2 hours. So in that first 2 hours, she stays in the labor or delivery recovery area. She is bonding with the infant. They're starting to breastfeed if that's the choice she's made, or they're doing kangaroo care. And all the while, the nurse is watching the baby and watching the mom. Okay, and then she'll be moved to the postpartum unit. Medical management for postpartum hemorrhage. Obviously, we need to stop the blood loss. We're going to give IV fluids to maintain the circulating volume, do a blood transfusion possibly, oxygen to increase the saturation of the remaining blood cells, and possibly an indwelling Foley catheter to assess the urinary output and the kidney function related to hypovolemic shock. Nursing management, we're assessing vital signs every 15 minutes until the client is stable. Things were in early postpartum hemorrhage, early signs of shock. Well, it doesn't have to be early postpartum hemorrhage, I guess. It's just with the postpartum hemorrhage, we're looking for early and late signs of shock, which you all have already discussed, I believe, in Health Eve. But early signs of shock, we're monitoring for tachycardia, pallor, cold and clammy hands, decreased urinary output. When we get to this late sign of shock, we got decreased blood pressure. That's obviously a late sign. We're doing routine frequent assessment of the lochia. It helps determine if the bleeding is increasing or decreasing. Anemia occurs after hemorrhage, obviously, so we've got to monitor for that and treat or educate on treatment. Postpartum infection. After the initial dangers of postpartum hemorrhage and shock have passed, the primary danger is going to be infection, especially uterine infection. This is called puerperal sepsis. Puerperal sepsis. All right, the risk factors for postpartum infection is the uterine cavity is now easily accessible to microorganisms because the cervix is dilated and opened all the way, and even after delivery, it doesn't close all the way. So the placental site is like an open wound in the uterus. It's easy access for microorganisms. Surgical incisions, such as an episiotomy or a C-section incision. Cracks in the nipples of the breasts are a good source for microorganisms to get into. and the physiological increased pH of the vagina after birth increases that risk for postpartum infection. So postpartum changes, what should we be looking for or noticing? Uterine changes. The uterus, we're wanting it to involute. So involution is the uterus returning to its pre-pregnancy size and condition. It's pretty rapid reduction in size and weight. It returns to its pre-pregnancy size by 5 to 6 weeks postpartum. And that involution process begins immediately after delivery. Now, if we have subinvolution, which was one of the risk factors for late postpartum hemorrhage, that is failure of the uterus to return to that pre-pregnant state after 6 weeks. The placental site, we're also checking to make sure, well, we can't assess this, but what should be happening in the uterus is that the placental site should be fully healed in about 6 to 7 weeks postpartum. Normal changes with the uterus, it should be easily felt through the abdomen. The fundus, or the top of the uterus, should be easily felt through the abdomen. We want it to be midline at the level of the umbilicus. Midline meaning we don't want it to be deviated to the left or the right side. The fundus should not be over to the left side or over to the right side. It should be right in the midline, in the middle of her body, of her abdominal cavity, and hopefully at the level of the umbilicus immediately after delivery. And then I think we've already talked about, but I'm going to show you again about how it's going to involute after that. All right, it should be a firm mass. It's about the size of a grapefruit. After delivery of the placenta, where is the fundus? Well, I just told you, the fundus should be at the level of the umbilicus once the placenta has been delivered. The uterus descends 1 centimeter or 1 finger breadth per day below the level of the umbilicus. Be sure you see page or figure 9 I think it's page 201 in your book. So if it's going to descend 1 finger breadth or 1 centimeter per day below the level of the umbilicus, we've showed you this before, fundal height at delivery is a bit above, or right immediately after delivery, it should be right at the level of the umbilicus. Day 1 should be 1 centimeter or 1 finger breadth below. Day 2, 2 finger breadths or 2 centimeters, same thing. Delivery, 2 days, 4 days, 6 days, should be 6 centimeters or 6 finger breadths below, okay, the level of the umbilicus. But all of these pictures are showing you midline, because what could happen is this fundus could be over here or over here, and we don't want that to happen. So we're assessing that it's midline and where it is in relationship to the umbilicus. So if the woman is 10 days postpartum, where should the uterus be? Actually, it should no longer be palpable. At 10 days postpartum, the uterus should have involuted down below the level of the symphysis pubis and should no longer be palpable. At 6 weeks postpartum, it should be back to its pre-pregnancy state or pre-pregnancy size. Then we have things called after pains that occur, that's uterine cramping or contractions that occur after delivery. These can be very painful. It feels just like they're normal contractions, and it's upsetting to some moms because they felt like, I just went through labor, why am I having this now? But what it's doing is helping the uterus to clamp down and involute. It's a good thing. You want it to happen. But do you think that these after pains occur more often in nulliparous or multiparous women? And you may have to go back and look up those terms to make sure you know what is nulliparous and what is multiparous. Okay, but it's going to occur more often in the multip woman. So with each subsequent pregnancy, these after pains get worse and worse, and sometimes they don't like that. The moms are very upset about that, and I usually just tell them that's what's going to happen every time you have a baby. It's going to get a little bit worse every time. All right. So with documenting the fundus, oftentimes you're documenting I wish I could show you all, but I don't have the option to put like a whiteboard or anything up on here. But we would document this as F/U/U. So this right here, if I did this fundal assessment and this was the assessment that I found, I would document this hopefully as FUU. And what I'm documenting is that the fundus is firm, that it's at the level of the umbilicus. Now, if we're documenting right here 2 days postpartum, and I came in and did this lady's fundal assessment, fundal check, and I checked her fundus and it was good and firm, but it's down here, I'm going to document that as FU2. F meaning firm, U meaning at the umbilicus, and 2, it's 2 centimeters or 2 finger breadths below the level of the umbilicus. So it's FU2, 2 centimeters below. If the fundus were not at the level of the umbilicus, but maybe above the level of the umbilicus, which does happen sometimes if they haven't voided lately and their bladder is pushing up on their uterus and causing the fundus to be higher than it should be, often it'll be tilted to one side or the other as well. You would document that as, if it's firm, F is for firm, and 1 U, so at firm and 1 centimeter above the level of the umbilicus. Okay. Some people don't document the F. They will just document U1, U2, U3, that whatever. I've seen it documented in several different ways. All right, lochia, vaginal discharge after delivery. We've got lochia rubra, lochia serosa, and lochia alba. And I had that slide for you all earlier that had what it was all consisted of, and you're going to need to know that. So rubra is days 1 to 3 postpartum. This is red. Serosa, it's mostly composed of blood. Rubra, red. Lochia serosa is days 4 through 10 postpartum. It is a pinkish in color, and it's mostly consists of blood and mucus. And then you have lochia alba. This would be after 10 days postpartum, and that's usually clear or colorless or white, but mostly mucus at that point. All right. The lochia is measured as scant, light, moderate, or heavy. Be sure you see skill 9-2. For nursing care, the fundal checks are done routinely at least once a shift. And what are we assessing for? We're assessing for firmness, location, and position in relationship to the umbilicus, really is really what this should be, is in relationship to the umbilicus, because we're assessing for firmness, we're assessing for location, meaning where is it in relationship to, or is it midline or deviated to the right or left, and where is it in relationship to the umbilicus. Okay, so what should the mom be taught to report to the healthcare provider? This is on page 203 in your book. She should be taught to report foul-smelling lochia, lochia rubra beyond 3 days postpartum, unusual heavy flow of lochia. If she maybe had changed to lochia serosa or even lochia alba, and then all of a sudden it returns back to bright red bleeding, for whatever reason, it doesn't matter. She needs to call the physician. Those are abnormal changes. Okay, and we talked about this, the scant, moderate, heavy amounts of bleeding. Uterine atony. Atony means no tone. It's boggy or soft. I've had several students that have had a hard time understanding the word boggy. I don't really know how to describe it, except that I think of it like as when you go to a marsh, if you go to the beach or somewhere like that and you're on a marsh, it's very boggy. It's really squishy. Okay, that's boggy or soft. Uterine atony is the #1 cause for postpartum hemorrhage. The uterus doesn't contract effectively, thus allowing more bleeding. When it's contracting, it's clamping off those blood vessels and not bleeding. If it's not contracting, it's bleeding more. So then the uterus feels boggy or soft. Causes for uterine atony are prolonged labor, retained placental fragments, uterine overdistension, drugs during labor that relax the uterus, and a full bladder, if not corrected, can cause atony. So I've done many fundal checks that I've gone in, and the fundus is kind of boggy and sometimes can't even tell where it is. Sometimes I can find it, but it's deviated to one side or the other. It's not midline, and it's higher than I would expect it to be in relationship to the level of the umbilicus. And what I would do is ask the mom, when did you void last? Why don't you get up and try to void for me again? And I'll be back in a few minutes. And I'll go check my other patients and then come back and check again and see if that helped. Emptying that bladder helped to the uterus to contract and come back to midline, and be where I would expect it to be in relationship to the level of the umbilicus. All right, so we talked about this before with doing the postpartum fundal checks. One hand is placed down here at the level of symphysis pubis, one hand up here, and usually you start just a bit above the level of the umbilicus with the curve of your hand, and then you move down to wherever you feel the top of the uterus or the fundus, okay? Should feel firm. I usually tell patients it feels firm, kind of like a basketball in there, and that's good. That's what it should be feeling like. And so then you're just documenting, is it firm? And you also need to be assessing the lochia at the same time as well to see if, doing the fundal massage or getting the location, the fundal height, is that causing more bleeding? Okay. All right. When the uterus is boggy, what should the nurse do? Well, the nurse should massage the uterus until it becomes firm. So be sure you see skill 9-1. How to firm the bladder. How to firm the uterus. If the bladder is distended, we need to have them go up and void first, or catheterize them if we can't get them to void. We can get them to breastfeed, because breastfeeding causes the pituitary gland to secrete oxytocin, which causes uterine contractions. We can give them Methergin, Hemabate, Cytotec, or uterine packing. Now, if we give them Methergin, we need to check their blood pressure first. And we've already talked about Cytotec once. We talked about Cytotec with softening the cervix, with inducing labor. So we can also give Cytotec to, usually you're going to give PO Cytotec for hemorrhage or for bleeding, and the Cytotec intravaginally for softening the cervix. All right, cervical changes. The cervix regains muscle tone, but it never closes as tightly as its pre-pregnancy state. The nulliparous cervix is circular. This is the one who's never had a baby. And this is the multiparous cervix. The cervix is a slit or a line because it never regains all of that tone. Vaginal changes. The vaginal wall becomes smooth during pregnancy and delivery. The rugae then will reappear about 3 weeks postpartum. When is it okay for a woman to resume sexual activity after delivery? Well, the answer is she needs to wait at least 6 weeks, at least. The vaginal bleeding needs to have stopped. She needs to give that much time for the perineal area to heal and for her body to heal. Now, I tell all my patients 6 weeks, and then I tell them all that a lot of people don't wait 6 weeks. So be sure you're doing something for birth control. It's not like 6 weeks is the magic number either. You still got to have birth control at 6 weeks or before 6 weeks. It doesn't matter. We're also going to recommend Kegels exercises, and Kegels increases that muscle tone, right? All right, perineal changes. The perineum. Be sure that you see these skill 9-3 and 9-5. The perineum can become edematous, tender, and bruised. We may have an episiotomy or a perineal laceration, in which case we assess RETA. That's redness, edema, ecchymosis, discharge, and approximation. We're inspecting the perineum for the type and amount of discharge and unusual swelling, bruising, the healing of skin tears or episiotomies, and assessing for hematomas. And you really do have to look at the woman's perineum. So you have to get her to spread her legs far enough to do that, or you can lay her on her side and lift up basically the top butt cheek and be able to see the perineum. But you really do have to assess the perineum. It's a huge source of infection and or hematomas or anything else, so we've got to be looking at it. We've already talked about these episiotomies. This is the fetal head crowning, and remember we talked about the positives, pros and cons for the midline and pros and cons for the mediolateral episiotomy. Here's a nice big hematoma. I mean, this is painful. Can you imagine? Painful. We need to be able that we are assessing that and monitoring it and making sure that it's going down, okay? If we don't look to see these things, this is a problem. Here's another hematoma, okay? Pericare postpartum, we're going to use ice packs for the first 12 to 24 hours. They are like this in a cold pack thing, just like you would have in a first aid kit. Has kind of like a little bubble in there. You pop the bubble, then you shake it up, and it gets nice and cold. Then we have a sitz bath right here. You use that usually after that first 24 hours. See Skill 9.4 in your book for more information on the sitz bath, and hopefully we'll talk about that some in class. We can do peri-care after each void or bowel movement, especially with this peri bottle. And the peri bottle, you just fill up with warm or cool water, whatever's more comfortable for the client, and have them squirt it on the perineum as they're voiding or having a bowel movement. One of the great things about this is it will neutralize the acidity of the urine, so that if they have stitches or tear or whatever on the perineal area, it's not burning when they pee. So that helps. We can also do topical and systemic medications like hydrocortisone and pramoxine. That's the epifoam that we use. Benzocaine or dermaplast spray, which is kind of like a numbing spray, or witch hazel or Tux pads. Okay. Breast changes. The breasts are full and soft the first 2 to 3 days. By day 3, the breasts start usually becoming a little bit more firm. Why? Well, they become a little more firm because the milk is coming in. The mom may actually develop a fever with this, and so that's something you have to watch. You're doing vitals on your patient anyway. Your patient develops a low-grade fever, we can do a huge workup, or we can find out if her milk is coming in, and we may be doing both. Okay. Breast engorgement can occur. This is where the breasts get very hard, the nipples are very erect. It's very uncomfortable. It's very hard for the baby to latch on because it's like a big hard melon or whatever there. Very hard to latch onto to release the milk that will help prevent breast engorgement. With nursing care, we are monitoring the consistency, size, shape, and symmetry of the breast. We're inspecting the nipples for any redness and cracking. And if the mom is breastfeeding, we definitely need to be assessing how that latch is. Is the baby getting all of the areola or just the nipple? Now, we've talked about this many times before. What is excreted from the breast the first few days postpartum? Very rich in antibodies and called liquid gold. Colostrum. All right, managing breast pain. If they're breastfeeding, they can use heat and warm compresses, warm showers, a well-fitting support bra. If they have sore nipples, we need to correct the latch. They can also use lanolin cream, and we need to teach them how to break the infant's latch. So when the baby is latched onto the nipple, I don't care how dead asleep you think they are, as soon as you try to pull them off of the breast, they start sucking like there's no tomorrow. And if you just rip them off while they're sucking, that is going to hurt horribly. So you have to take your little pinky finger, it needs to be clean, obviously, put your pinky finger in their mouth, between your breast and their mouth, and you break that section before you take them off of the breast. Obviously, we've got to have proper hand hygiene with breastfeeding. That's what I was just talking about. Mastitis can occur. This usually occurs about 2 to 3 weeks postpartum. It occurs from organisms entering the small cracks in the nipples. Signs and symptoms will be redness, heat in the breast, tenderness, and edema. And you can see more on page 246 for this. Treatment is going to be antibiotics and getting that milk off of the breast, removing that milk of the breast. Number 1 cause of mastitis, milk stasis. Means she's not breastfeeding frequently enough, or the baby's not emptying the breast fully or whatever. If they're bottle feeding, we tell them to use cold compresses or ice packs wrapped in towels, wear a nice tight-fitting sports bra or a breast binder. We can wrap their breast with an ACE bandage. Tell my patients no nipple stimulation, no warm water or warm compresses. Don't stand in the shower and let that warm water hit your breast, because that's going to help your milk to come in. You don't want that to happen. When a mom has been fully informed of the benefits of breastfeeding and chooses to formula feed, what is the role of the nurse? Well, it is our role to provide support and reassurance and encouragement. And I do feel very, very strongly about this, because I feel like in our society, we are really pushing breastfeeding. Your baby's going to be dumb or sick or any number of things if you don't breastfeed. And, breastfeeding is not for everyone. There may be medical reasons why she can't breastfeed, or personal reasons why she doesn't want to breastfeed. So our role as the nurse is just to provide lots of education. It's not to guilt them into breastfeeding. It's not to say, oh, I can't believe you're not going to do this for your baby. It's the best thing for your baby. Breast is best. And your baby's going to be dumb because you give it formula. I mean, your baby's going to be sick all the time because you're not breastfeeding. That's not our job at all. And I feel like I've seen people do that before. Our job is to give them all the information for breastfeeding and formula feeding, let them make their own informed decision, and then be supportive of whatever that decision is, okay? Formulas come in 3 different forms. We can get ready to feed, powder, or liquid concentrate. Formula feed every 3 to 4 hours. Can you microwave formula to warm it? Well, the answer is no, but how many of you have done it? I'd say everyone that has a baby or has ever done formula. But it is not recommended because it heats the formula unevenly and can cause hot spots, which could scald the baby. Be sure you see page 231, 232 for formula feeding information. The newborn stomach size. It is really important to realize how big the newborn stomach is because as parents, they often worry that the newborn isn't getting enough milk. So at day 1, this is how big the stomach is. It's tiny. So 5 to 7 milliliters, 1 to 1.4 teaspoons. That's about all that's fitting in there really at a time. Day 3, week 1, and then at a month. Okay. Postpartum assessment. Be sure you see table 9.1. This is a very good mnemonic that you can use to help you with your postpartum assessment. Bubble heat, breasts, uterus, bladder, bowels, lochia, episiotomy, Hohenstein, and emotions. So breasts, are they soft or engorged? Uterus, is it firm? Where is it location-wise, and where is the fundal height? Bladder, we're looking at bladder distension. Bowels, are they passing gas? Are they hearing bowel sounds? Has she had a bowel movement yet? Lochia, what is the character, amount, color, odor? Are there any clots in the lochia? The episiotomy is checking the perineum. Hohenstein, that's when you have calf pain when the foot is dorsiflexed. And Hohenstein is a controversial thing right now. Lots of people are saying it doesn't really help determine if the patient has, the purpose is to determine if the patient has a DVT. But newer studies are saying there's really no evidence that this is really showing if the patient has a DVT or not. So, you know, I put it in here because it's in the acronym. I personally still do it probably out of habit more than anything else, but it is not used often anymore. And then emotions, we're assessing family interaction. Cardiovascular changes. What % increase in the blood volume does the mom have during pregnancy? Hopefully you recall that's pretty big. It's 50% increase. In the EBL, that was estimated blood loss for spontaneous vaginal delivery was 500 mils. EBL for C-section, 1,000 milliliters. Maternal vascular system must make dramatic and immediate changes. The body rids itself of excess fluid via 2 mechanisms. One of them is diuresis, meaning you pee it off, and the other is diaphoresis, meaning you sweat it off. All right, blood clotting factors are higher, therefore we have an increased risk for an embolism. These 2 symptoms, signs and symptoms, are hallmark signs and symptoms of a pulmonary embolism that require immediate medical attention. Pulmonary embolism, dyspnea and tachycardia, dyspnea and tachypnea. Dyspnea and tachypnea. We're going to do a hemoglobin and hematocrit. Will it be increased or decreased related to the dilution of the red blood cells? It's going to be decreased. It usually does return to normal by about 8 weeks postpartum. The mom will experience chills or tremors immediately postpartum in that first 1 to 2 hours postpartum. There are many different theories for this. It's thought to be from the release of pressure on the pelvic nerves or more of a vasomotor response. It's also thought to be related to fluid shifts from all the fluid shifts that are happening with the labor and delivery process. Usually resolves within 20 minutes to an hour. So you just need to reassure the mom because it's kind of freaky. You can't control it and you're literally shaking, trembling is awful. And it looks like you're freezing cold, but you're really not even cold. Orthostatic hypotension can occur. It usually occurs from a drop in the blood pressure when the mom sits or stands. Therefore, goes from sitting to standing, and we must educate that she has to call out and get help, especially the first time she gets up. So the first time she gets out of bed after delivery, she's got to have some help, because orthostatic hypotension happens frequently. I cannot tell you how many moms, even with help, fortunately, they've had the help, they've called out, and the help has gone in, and as soon as they stand up, down they go. Urinary changes. We have decreased tone of the bladder and ureters related to pregnancy, with increased IV fluids during labor that cause the bladder to fill quickly and empty incompletely. Possible complications related to this issue could be postpartum hemorrhage or a UTI. The nurse has to regularly assess the bladder and the fundus. By assessing the fundus, we are somewhat assessing the bladder. We are encouraging voiding. We're monitoring urinary output. The mom should void within those first few hours postpartum. If she has not voided by about 6 hours postpartum, she needs to get catheterized again. And we encourage Kegels exercises, or Kegels. All right, Kegels exercises to strengthen that pelvic floor. GI changes. The mom is usually hungry or not hungry after delivery. Usually she's very hungry. All right, she's hungry after delivery. She wants to eat. Another GI change is constipation. That can be an issue, and that can be related to medications that we've given her that slow peristalsis, possibly the fact that the abdominal muscles are now stretched out significantly, hemorrhoids or soreness, or she may just be scared to have a bowel movement. She may be slightly dehydrated and not have as much food intake because now she has to care for the baby, and learning how to juggle all that can be a challenge. The nurse should encourage increased fluids, fiber, ambulation, and a stool softener if ordered. And pretty much it's always ordered, and you should always give it. You shouldn't wait for the patient to ask you for it. You should just give it to them. Integumentary changes or skin changes. This should be a review, as we discussed this very early on in the semester. We may get hyperpigmentation of the skin, such as chloasma, the mask of pregnancy here, the linea nigra here. Those disappear as the hormone levels disappear, and striae, stretch marks. Okay, they fade from reddish purple to a silver color. Musculoskeletal changes. Many moms are upset to see that they still look pregnant after delivery. Why is that? Well, mostly it's because the abdominal muscles are still very relaxed. They're not very tight, and that just happens. That can come back and will come back, especially with some exercise. But they could have this diastasis recti, which is where the abdominal muscles are actually separated from the pregnancy, or anything else. You can have diastasis recti from obesity as well. Going to have joint hypermobility with pregnancy, and that will return to its pre-pregnancy state within about 6 weeks. We're going to return to exercise immediately after delivery unless you had a C-section. You may need to wait a little bit longer. The things we're going to try to suggest or recommend: abdominal tightening, head lift, pelvic tilt, Kegels. All these exercises can really help with that abdominal muscle and perineum floor muscles. Immune system changes. All right, we've got the Rh immune globulin, the rubella status. Those titers are drawn early in pregnancy. If you're not immune, a vaccine is given immediately postpartum to prevent complications with subsequent pregnancies. I just realized I think I had that wrong. No, that's right. No, that is right. Okay. If the baby is in the NICU, rubella can be fatal for newborns. It has a lot of can have some teratogenic effects. If the baby is in the NICU, the mom may not get this vaccine immediately because it is a live vaccine, and so they don't really want it going to the NICU with these sick babies, so they may give it to her upon discharge of the baby from the NICU. All right, emotional changes. Table 9.2, psychological adaptation postpartum. We've got the taking in phase, the taking hold phase, and the letting go phase. You hope you guys need to be able to understand these differences. The taking in phase is early postpartum, those few hours to 2 days. Mom's very passive with the care. She talks about her birthing experience. She's really focused on food, fluids, and restorative sleep. The taking hold phase, this is about 2 days postpartum to several weeks postpartum. The mom cares for the infant, has an increased concern for body function, cares for herself. She's interested in learning about caring for herself and the baby. In the letting go phase, this is 2 weeks to 6 weeks postpartum. The mom lets go of her previous roles and now sees parenting as her primary role. She reconciles with the way the birth actually went versus how she wanted it to go. Postpartum depression. Postpartum depression is a huge thing, and hopefully somebody picks that to do their presentation on as well, or a group. There is a difference between postpartum blues, postpartum depression, and postpartum psychosis, and you need to understand that. Postpartum blues, also known as the baby blues. It's normal to feel a little bit down, a little bit depressed, just a little sad, but it shouldn't be, you should be overall happy with life. All right. Postpartum depression usually occurs about 2 to 4 weeks postpartum. It's a persistent mood of unhappiness. The mom can't care for herself or the baby. She's disinterested in others, gets very disturbed sleep, is constantly fatigued. And then we go into postpartum psychosis, which is an impaired sense of reality. Moms who are at risk are those with bipolar disorder, major depressive disorder. And this can be fatal for the mom or the infant. I mean, we've all heard very unfortunate fatal stories like that. Now, postpartum blue, all of this, I talk to the mom about, but when I do this teaching, I really try to talk to somebody else, also a significant other or a parent or somebody that's also going to be helping, grandparent that's going to be helping with the mom and the baby, because we often don't recognize these things in ourselves, but we'll recognize them in someone else. So I teach it to the moms. I want them to be able to recognize it in themselves, but most often someone else recognizes it, these depressive issues. And I always tell my moms, it's way better. You definitely need to call the physician. There's nothing to be embarrassed about. You cannot tell them anything that they have not already heard. It would be so much worse if you didn't call them and waited to see what happened and hoped it got better. And what if it doesn't get better? There's just no shame in it. There's absolutely nothing to be embarrassed about. And you can't say anything that the physician will be shocked about. Okay, they've heard it all. We've heard it all. We'd rather hear from you. Postpartum care and teaching, preventing infection. Very big first thing is good hand hygiene before and after. You touch the breast, you feed the baby, you provide infant care, you use the bathroom or perform pericare, any dressing changes, and before and after you eat. We need to definitely encourage early ambulation. If they're a C-section, return, cough, deep breathe, or use a Respirex immediately after the surgery. Pericare, we need to have the client void at least every 4 hours. And I know that sounds like, why do you have to tell somebody that? But I'm going to tell you, you have to tell somebody that. How often do you need to change the sanitary pad? At least every 4 hours. I cannot tell you how many clients I have told, you need to get up and go to the bathroom. When was the last time you changed your pad? Oh, it was this morning, and now it's, 7:30 at night. I just got on shift for my night shift. I'm amazed. So, you got to educate them. Sometimes you got to remind them to change that pad every 4 hours. So they need to be avoiding at least every 4 hours. And when they get up to void, they need to change the pad. They need to know how to cleanse the perineum from front to back. They can use that peri-bottle or a sitz bath. The sitz bath and the peri-bottle, but they recommend the sitz bath at least 3 times a day. Need to tell them about when to call the doctor. If they have increased vaginal bleeding, increased pain, or increased depression. Daily showers, no tub baths, no tampons, douches, or sexual intercourse, or anything in the vagina for at least how long? 6 weeks. 6 weeks postpartum. That's what I tell everybody. No tampons, douches, sexual intercourse for at least 6 weeks. And then I turn around and talk about birth control. Discharge teaching. Follow-up appointments are usually at 2 weeks for a C-section. A C-section usually comes in at 2 weeks postpartum and 6 weeks postpartum. A vaginal delivery comes in at 6 weeks postpartum. Birth control, we talk about what do we want to use for birth control. They really should know that before they leave the hospital, whether we're going to provided, if they're going to be on the oral contraceptives. Are we going to give them some, go home with oral contraceptives? Are they going to get a tubal ligation? Are we going to do that while they're in the hospital? Or are they going to come back for that at their 6-week visit? What do they plan to use? And if I heard it once, I heard it 1,000 times, well, I'm not having sex again. Yeah, you are. And you probably do it sooner rather than later. So you need to have some birth control. Eat a well-balanced diet, get moderate exercise. Again, we've got to teach about when to call the physician. If the mom has a temperature greater than 100.4, has a foul odor to her discharge, has increased bright red bleeding, etc. All those things we've talked about. We need to encourage rest often. I usually tell my moms not to be mean or anything, but when people come over to visit, they really just want to see the baby. So take advantage of that time. Go take a sitz bath. Go take a nap. They don't need to be entertained. They don't want to be entertained. They don't want you to fix them food. They just want to come and visit the baby. We've got to educate about car seat use and placement. Now, we can't put the car seat in the car unless you've been car seat certified, but we can educate on how to work the car seat, how to put the car seat in, how to make sure that these straps are nice and tight. The parents do not like these straps to be tight, and that scares me to death. They also do not put this strap up very high. This bar needs to really be up at the level of the armpits, which for these little newborns is pretty much right up under their chin. Otherwise, you have an accident and they just slide right out through the top. I mean, that's the purpose of that, is to keep them in place. So many car seats are used incorrectly. They have a car seat, they think they're safe because they have the car seat, but they're not using the car seat appropriately. All right, be sure that you let me know if you have any questions about this lecture.